today's webinar. This is Jonathan from TMC Academy, and today we are with Professor Avisala. We are going to take 3 minutes to start the webinar, so all the people that are joining the session. Okay, more than 100 people at the moment. Thank you so much for your assistance today. We are really happy to welcome all of you. Can you hear me well, Evis?
Yes.
Yeah, okay, thank you.
Can you hear me well?
Yes, as well.
Perfect, excellent.
Okay, just 1 minute because I am admitting more people that are in the waiting room, and we are starting in just 1 minute.
Oh, somebody says we hear bad.
Yeah, probably because my microphone was not close to my mouth.
Okay.
Yeah.
I can hear you, both of you, very well.
Okay, thank you, sir.
Excellent, thank you.
I thought I just mentioned.
Thank you so much.
Thank you.
Okay, Abby, so let's start. Good afternoon to everybody, and welcome to today's webinar. Today we have a very special guest, Professor Avisala. Avisala is Professor of Oncological Imaging at University of Cambridge and consultant radiologist at Cambridge University Hospitals in Cambridge, UK. And she is a mentor of TMC Academy, and she collaborates us as well with her colleagues, Susan Freeman, by organizing a very popular pelvic female imaging online fellowship. So if you are more interested in today's topic and you would like to have a clear look at it, I recommend you to have a look at our amazing online fellowships. During the webinar, please, if possible, stay muted. And in the case you have questions, please type them on the chat, because at the end of the webinar, we will have 15 minutes of Q&A. So you will be able to make all the questions that you have to Professor Avisala. Also, for all the attendees, we will grant you access to the recording. So you will have access through our website. And we will send you a follow-up email with all the data from tomorrow onwards. Okay. Also, this webinar will be accredited. Okay, so this is something that you are getting credits for free. I hope that you made the most of it today. Thank you so much, Evis. It's a pleasure to have you on board, and thank you to all the 125 attendees at the moment. I am admitting people on a regular way, so it seems that today's webinar is really popular, and I hope that you enjoy it. Thank you so much. I'm going to start to record the session, Evis, and the stage is yours.
Thank you so much. Let me share the screen.
Yes, the
Okay.
recording has started, so
Okay,
let's go.
no problem. So can you just confirm that you see the first slide in a presentation mode?
Yes.
Fantastic. Okay, so what we're going to do in the next 45 minutes, and I'm saying we because we're going to do it together, it goes through how do I approach characterization of adnexal masses on MRI or adnexal lesions on MRI. So the talk includes about 8 cases. I know that the webinar is not really set just to be interactive, but if you know the answer, I'll leave it for 5 seconds, type it on the chat. We can go back to those cases and discuss them. But after each case, I'm going to talk about that pathology. So I hope it's a bit more interactive than, than just a standard sort of a webinar. Okay, so what are the objectives of today? We want to provide a practical approach of how to characterize an adnexal lesion on MRI. And when I read those MRI cases, I take into account certain things, not just the imaging per se. The age of the patient, the clinical history and symptoms. Don't forget, after all, we are clinicians. The lab data, very important on the adnexal lesion characterization, because almost sometimes a couple of pathologies, by looking and knowing the lab data, you almost make a diagnosis without even looking at the images. So you have a high pretest probability of being absolutely correct. The MRI finding, of course, this is why we're here. And when it comes to the MRI, I'm going to go on a stepwise on what are the main areas you have to concentrate. First, the lesion origin, where is it coming from? The signal intensity, the morphological features, very, very important. And also then the enhancement and diffusion characteristics. But I'm a big believer of morphological, standard T1, T2, you can characterize about 80% of adnexal lesions. And as we go through those cases, I'm going to highlight a couple of pearls and pitfalls, which are very important. So I don't want you to be in any doubt that you have to use MRI as a first imaging modality to characterize adnexal lesion. No, the first imaging modality is an ultrasound. It's a first-line technique. Yes, we know it's operator dependent and also patient dependent. However, in the majority of the cases, we'll characterize the lesion beautifully. This is an example here of a patient with a solid cystic lesion or cystic solid lesion, or even better, cystic lesion with a solid component. You can see there is flow within the solid component. This is a malignant lesion. Coupled with a ratio 125 that made the diagnosis of ovarian cancer. However, in about 20% of the cases, the findings can be indeterminate. If the lesion is big, it can be difficult to actually assess the origin of the lesion. Is it coming from the uterus? Is it coming from the ovary? Is it coming from other parts of the pelvis, neither uterus or ovary? And ultrasound, while it's very good at characterizing cystic lesions, it's actually difficult to sometimes characterize purely solid masses or the very complex cystic masses. So, and I already touched into the body habitus, and also sometimes some patients, especially the adolescents, will have a reluctance to undergo transvaginal ultrasound. So for all these reasons, in about 20% of the cases, we need to go to MRI. So why would you use the MRI? Well, we evaluate the adnexal masses that are indeterminate ultrasound, and it's great because the majority of them are going to be benign. So you either avoid surgery altogether, or the surgery is much less invasive. It doesn't have to be a cancer surgery. It's a keyhole surgery, and you don't really have to go through the extensive sampling of the omentum. So benefits either way to the patient. In the minority of them, they'll be malignant. And for that one, MRI is actually very good, not only because it characterizes the lesion, but also it's got a timely diagnosis, and then it triages the patient to the right treatment. It's excellent for lesion characterization, and it is actually cost effective. If you compare with the ultrasound, they both have a excellent sensitivity, where the MRI actually jumps the ultrasound and is better is the specificity. And this is what we're looking when we do this characterization of adnexal lesions. So what is the MRI protocol? And I'm going to the protocol that we use in our center. It doesn't mean that it's the best to use. I'm just giving you an example. And ultimately, you have to use what works for you. Now, I'm not a big fan of contrast. So in our center, we hardly use contrast for adnexal lesion characterization. But it's very good. And I'm going to give you an example where it actually helps. So we always do T1 weighted images of the pelvis without and with fat saturation, because this is key for lesions that contain fat or blood. Then we do high resolution T2 weighted images in the sagittal, axial, and coronal plane. And those are the straight planes to the pelvis, not to the ovary or the uterus. So this all takes about 20 minutes. Then we routinely do diffusion weighted images with multiple B values. And also, if we think there is, if we are looking at the images, and sometimes we supervise, sometimes we don't. But if we look at them, we also do the diffusion weighted image of the upper abdomen. So this whole protocol is about 25 to 30 minutes. So we aim for about half an hour scanner time. The contrast enhanced images, the dynamic multiphase or GC, are optional. So we use them very rarely when there is a question for the adnexal lesion characterization, which the diffusion didn't answer the question, or when the research setting. And we reviewed recently our last 10 years of experience, and we had only recalled 3 patients altogether to give contrast. So, however, you really need to get your diffusion weighted images very good. So you really need to work with the physicist and the application specialist. So if you do that, we'll have another 5 minutes, and then the upper abdomen only if there's suspicion of malignancy. And what do? We do an axial T2 weighted images, and then the diffusion as well, as I have outlined here already. So this will get you to a 40-minute scan. Now, very rarely we will do that. I believe in, once, if you've supervised the scan, or if your technician will come and say, listen, I think it looks like malignant, if the patient is there, do the upper abdomen and finish the study. But most of the time you don't supervise, so that is fine. And then if it's malignant, that will require CT, chest, abdomen, pelvis, or spare the pelvis, because we've done the pelvis here. And I just want to highlight the ESUR recommendation for MRI imaging in indeterminate ultrasound masses. A really, really nice work done by the ESUR group led by Rosemary Foster. So just a word on signal intensity time curves. I believe in simple, and I believe in giving right, the diagnosis rather than categorizing lesion in certain sort of categories. So I'm not a big fan of RUDS systems in a way. But just that is there in the literature, you would see the various types of enhancement. This is the same as breast. The people in the audience will do breast. This is exactly the same. So type 1, weak gradual enhancement, no peak. Quite a good sensitivity and specificity for benign tumors. Type 2, moderate and plateau. Reasonable, and then type 3, it's actually the malignant one. I don't use this in clinical practice, but just I want you to know, I want you to be aware there is publications out there, and this is taken into account. Okay, a word on diffusion. So you've got to use at least 2 B values for diffusion. Be very careful with diffusion. If there is no restriction, it's perfect, because it's very likely it's benign, so it's very, very helpful. If there is restriction in the lesion or part of the lesion, it's completely non-specific. It could be benign or malignant. You really have to put things together with your anatomical images, T1 and T2 weighted images. So diffusion on its own is not really helpful. You have to use the context of anatomy, but also what is really helpful if there is no restriction rather than restriction. And I'm going to show you examples of that. And why am I saying this? Because if you actually go by the philosophy that we go in general, if there is restriction, there is a cancer, you'll be wrong on very sort of common lesions such as endometriomas. This is such a case here. T2 shading, T1 fat sat bright, diffusion bright, ADC dark, So if you just looked at the diffusion and the ADC, you'd call this a malignant tumor. It's not. So go back to your anatomical sequence. And why? Because the blood products can actually cause quite a lot of restricted diffusion because the cells are quite dense together in a clot. However, it is very useful in a case like this when you have a cystic mass with the solid components and those solid components restrict. So putting all this together, you really don't need contrast for this. This is now an early ovarian cancer, as it was an early stage 1A ovarian cancer, high-grade serous ovarian cancer. So the way I approach Adnexal lesion, I approach as a puzzle. I used to love doing the puzzles with my little boy when he was little. And it's just the satisfaction at the end when you see the whole thing done and finished. But it takes quite a lot of work to actually put those pieces together. And this is really important. And that's what you need to do to get the satisfaction at the end. So age, very important. Why? Because you're going to have a differential if the patient is an adolescent, a younger woman, or an older woman. Clinical history, very important as well. Pregnancy status, clinical symptoms, past medical history and past social history. This is really important to sway you to a diagnosis of the other. Tumor markers, I stated at the beginning, very important. CA125, obviously, it swerves you towards malignancy, but if you actually have a lot of adenomyosis and endometriosis, you know, patients can have quite a high CA125. I've seen it certainly in the range of 400, 600, you know, in that range. And then other markers, very useful, inhibin, LDH, beta-ICG, and AFP. They'll tell you about certain tumor. And I'm going to show you examples of that. And of course, that's why you're here. We have the MRI features, as I already listed in the first slide. So once you put all of this together, you can really characterize those lesions beautifully, and you can be very, very accurate, reaching almost, you know, perfection if you put this all together. So, okay, so step 2. So that was step 1, getting all the clinical information, everything together in front of you, the blood markers, and then you start reading your case, obviously making sure you've got all the images and they're interpretable. Step 2, you have to identify each ovary. So it's the origin of the lesion. So to identify the ovary, it's easier on the premenopausal patients, obviously, because you've got the follicles and the stroma, and it's really easy. But on the postmenopausal patients, they can be a little bit more difficult. Just follow the gonadal vein. Most of the time, you'll find the ovaries. It should be over 90% of the time you should be able to find the ovaries, being that, you know, easy on premenopausal, but even if it's more difficult at the postmenopausal. The ovaries tend to be medial to the pelvic vessels. They can all be lateral. There's a differential with the lymph nodes, so medial to the pelvic vessels. So then, what is the origin of the mass? Once you've identified the ovary, you want to determine if the mass is of origin or if the mass is of uterine, or neither ovarian nor uterine. It comes from somewhere else. So if you see this big sign, you have this sort of really like a beak here with the mass, you clearly can say this mass comes from the ovary. You can see sort of the ovary at the top of the mass in this case. This is very dark on T2. We'll come to that diagnosis. It's fibrous tissue. It's as dark as skeletal muscle. This is clearly an ovarian fibroma. This can stay there forever. In the young patients, they tend to cause torsion. So, you know, and it's probably best taken out, especially if you can take it out with preserving fertility. So, however, the mass sometimes, it doesn't come from the ovary. You see the ovary separately. You can identify things like the bridging vessels, the flow voids, and this is the flow voids here with the bridging vessels from the myometrium to this adnexal mass here. The splitting of the myometrium there, this clearly comes from the myometrium. So this is a subserosal fibroid and not an ovarian mass. It can be a bit more complicated when they're pedunculated, but again, follow those flow voids that will attach this lesion to the myometrium in a way or another. Now we come to step 4. And this is where we've decided the lesion is ovarian, it's not uterine. Now we want to characterize it, okay? So as we get there, I try to sort of categorize the lesions into T1 bright, T2 solid, low signal intensity. And on the first part, actually the majority of them are going to be either endometriomas or mature cystic teratomas, with a few exceptions there. Lipoleiomyoma clearly coming from the uterus rather than the ovary, but bright on T1. On T2 solid lesions, it will be mainly fibromas and thachomas, but will also be the brain tumors, some of the germ cell tumors. They tend to be a bit more heterogeneous rather than really homogeneous solid. And then the complex cystic and solid lesions, broadly speaking, they either will be your benign ones, tubovarian abscesses, or the malignant epithelial ovarian tumors. And also to include there will be metastasis. Rare, but possible. So the first two, with just the homogeneously solid one, and the rest a bit more heterogeneous. So for the first one, you really need a 20 minutes protocol. For the second one and the third one, it's more of a comprehensive protocol with a diffusion. But if you're not just confident just using diffusion, by all means give contrast in order to avoid recalling patient back. We've reached that point in our group that we're confident, so our recall rate is very, very low. Right, I'm going to go do this through cases, and I'm going to give, about 5 seconds for each case. Then we're going to sort of go through the features and give the answer, and then we can discuss them at the very end. I think it just makes it a bit more fun. So here we have a 32-year-old female patient which presents with pelvic discomfort, and she has a previous history of necrotizing enterocolitis when she was 2 years old. She had surgery for that. So the MRI is done for characterization. So she had an ultrasound first, which showed a large lesion. It was outside of reach on the transvaginal ultrasound, as you can imagine, and they wanted an MRI. So there's one very important piece of information here. Even without looking at the images, you should have a diagnosis in your mind. Previous history of necrotizing enterocolitis. So surgery in this patient when she was little. That should sort of immediately bring diagnosis in your mind. So giving you a couple of seconds. Okay, so what do we have? Ovarian cancer, peritoneal inclusion cyst, a serous cystadenoma, or a dermoid cyst. I'm just going to try to see if I can actually see the chat without ruining the... Okay, no, I can't see the chat. That's fine. So, right, okay. So this is a peritoneal inclusion cyst. So now let's just discuss the features here. So there are benign lesions completely. They happen on a pelvis which have been an insult before, being that surgery, infection, trauma, endometriosis. The patient has to have a history of that. That's why it's very important to have that history. Also, the ovaries should be in. It does not happen if the patient had oophorectomy, so bilateral oophorectomy. So the patient have normal active ovaries because the production of the fluid is normal. What is impaired is the resorption of the acidic fluid from the peritoneal cavity because the peritoneum has been insulted by the surgery, infection, trauma, or endometriosis. Classic is central eccentrically suspended ovary. You see this ovary is suspended. This is a bladder here anteriorly. The ovary is suspending on this fluid, and the fluid kind of conforms, drops along the shape of the pelvis. It's not like a really nice tense cystic mass. It conforms to the shape of the peritoneum, and the ovary is really nicely seen encased or enclosed in that cystic space. It can have little septation. It can have what is called multiloculated appearances or a spider in the web. But it's very unusual. Occasional septa can enhance, but they shouldn't have any nodules. Once you have nodules, you just have to rethink your differential diagnosis, okay? So this was a peritoneal inclusion cyst. In a way, it doesn't come from the ovary or from the uterus. This is another pelvic lesion. Okay, case number 2. We've got a 28-year-old patient which presents with chronic pelvic discomfort. An ultrasound shows a complex lesion, and the MRI was requested for further characterization. And there we have a T2 weighted image here with a Adnexal mass on the right, the uterus here, the bowel. T1 weighted images without fat saturation. The mass is bright with a very well defined nodule. And then with fat saturation, there is a drop in signal intensity and the nodule remains bright or intermediate signal intensity. So this is the key. Bright, dark. Okay, so what do we have? Do we have a dermoid? Do we have ovarian cancer? Do we have an endometrioma? Or do we have a metastasis? So just remember, from bright goes dark. And the way to remember it, and this is certainly a dermoid, bright, dark is going to be dermoid D. If it's bright, remains bright, it's going to be blood products and endometrioma. Okay, so a few words about dermoids or mature cystic teratomas. So on T2, they have quite a variable signal intensity. On T1, they have high signal intensity that suppresses after fat suppression. So bright on T1 with fat suppression dark. They have macroscopic fat. They can have coarse tooth-like calcification hair. I mean, you've seen them on CT done for other reasons. And CT is very good when there is calcification. So I'm not saying that if you have a teratoma on CT, you should do an MRI. Absolutely not. That can be diagnostic. But from ultrasound, you then move to an MRI, not to CT. Then they can have the Rokitansky nodule, which can actually be intermediate signal intensity or dark. It's in a way, it's very well defined. The moment you have a lot of soft tissue, you have to be worried of malignant degeneration. We'll come to that in a second. So sometimes you have a lipid-poor mature cystic teratoma. And in those cases, it's useful to have in and out of phase images. This is extremely rare, about 5%. So do we use it in our protocol? We don't. But there's this one case I can remember bringing the patient back for in and out of phase images when we diagnose the lipid poor teratomas. Now be careful with diffusion. They are bright on DWI and dark on ADC, so they look like tumor, like malignancy, because they have carotenoid substance. The cells are very dense with each other. So diffusion actually doesn't help you on dermoids or endometrioma, as a matter of fact. So after contrast, they can have enhancement. This Rokitansky nodule can really enhance a lot. And why? Because it contains skin derivatives as well, right? So they'll have a lot of enhancement, but it's not an indication of malignancy. The only time you think of malignancy, if it's a lot of soft tissue, you almost lose the fat content. And it's very rare. And when it does happen, they degenerate into squamous cell carcinomas, not into epithelial tumors. Why? Because they contain derivatives of skin, right? So you have a squamous cell tumor. Okay, right. So, and because they have an increased risk of torsion, in those cases, usually the dermoids are taken out unless they're embedded within the ovary on a young patient, and then, obviously it's sensible to preserve the fertility. Okay, so case 3. This is now an 18-year-old. You see, it's a different age group. Pay attention to the clinical details. Presents with an abdominal mass, and what she came to CT. So she came via CT, which is absolutely fine because she comes from the emergency department. So CT here contains a little bit of fat, not too much fat. MRI, T2 and T1 weighted images. There is a little bit of fat on T1, but fairly cystic. And here we have a choice for our differential diagnosis. Is this a ovarian cancer? Is this a yolk sac tumor? Is this an immature teratoma? Or is this an ovarian torsion? So it looks cystic because the ovary is torted. I mean, there is a scientist on CT and on MRI. Okay, so I'll leave you, just remember she's 18, right? Okay, so this is an immature teratoma. So just go through the immature teratomas. They are very rare malignant ovarian germ cell tumor. The peak is on the first 2 decades of life, usually 15 to 19-year-old. When you see somebody with a mass like this in that age group, you have to think of immature teratoma. They tend to be large, unilateral, cystic solid masses, but actually fairly cystic. They can have small foci of fat and small areas of calcification like we saw in this case, but sometimes they don't have perceptible fat. And you can see here is exactly what I'm describing. The fat will suppress with fat saturation. But on T2, they're actually quite cystic in their appearances. One thing to remember, in about 10% of cases, they'll have a dermoid on the contralateral ovary. And you would say, why is it important? I mean, it's benign, the dermoid. Yes, it is, but since they're going to sacrifice this ovary, the ovary with a mass, the other ovary, they will have to preserve, to actually preserve fertility. So it's important to describe there's a dermoid because they might have to take it out at the time, same surgery, or if they can't, because it's embedded in the ovary, we'll follow that dermoid with repeat MRI. Okay. Right, case number 4. So in this case, we have a 35-year-old female patient with a history of infertility. And we want to review the CT. We actually only have the MRI to review here. We don't have the CT. So I don't think the CT was informative. And that's why actually the patient ended up coming to an MRI. Right, so what we do, we have a T2 here, 2 lesions, or maybe even 3. T1 weighted images. All 3 of them are bright. So 2 small lesions of different brightness on T1. Just pay attention to that. And one on the right. After fat saturation, T1 fat sat, the lesion on the right remains bright, even a little brighter. The small lesion on the left remains bright. The large lesion on the left loses signal intensity. So fat suppresses. Okay. Okay, so I've complicated things a little bit in this case. Okay, so I'm leaving the same images. What do we have in here? Do we have bilateral endometriomas? Do we have bilateral dermoids? Do we have a right endometrioma and a left dermoid? Or we have a left endometrioma and a right dermoid? Okay. Again, just remember, bright on T1 remains bright, blood products, endometrioma. Bright on T1, it goes dark after fat saturation. D is a dermoid, okay? And there's no reason why one can't have both, like in this case. So here we have a right endometrioma, shading, bright remains bright. Endometrioma. Well, actually, we have a smaller left endometrioma as well, but the main lesion here is this lesion here, bright on T2. It's kind of non-specific, the T2, but bright on T1, loses signal intensity, goes dark, is a dermoid. Now we went to the dermoid characteristics. I want to review the endometriomas with you. On T1, they are of high signal intensity, which persists after fat saturation. They're bright on T1, bright with fat sat, even a little brighter actually after fat saturation. You'd say, well, how we differentiate it from the hemorrhagic cysts? Well, the hemorrhagic cysts tend to have a bit more heterogeneous appearance, but there are other features. Endometriomas are not isolated. There'll be other features of endometriosis as well, but also they tend to be multiple. Like I showed you this exact case when you had a larger one on the right, but you have a tiny one on the left as well. So on T2, they have shading. So this gradual sort of darkness, you know, as you go with the shading effect. The other feature, this is a different case that you should look for. It's not it's present commonly. It's about 50% of cases. You have this little foci, these little balls, dependent balls of very dark signal intensity. And there are really foci of chronic hemorrhage. They're hemosiderin within the lesion. And when you see this, it's a very high specificity of about 93%. Diffusion, completely helpless, okay? Not useful at all. I showed you this case already, and this is the case, the top case here, dark on ADC, you know, where you don't really need diffusion. You know it's an endometrioma once you've looked at a T1, T2 and T1 with and without fat set. Do you give contrast? The only time we give contrast to endometriomas is that if we're following a nodule, which we probably decided was a retracting clot, but now we really, you know, or if there is a jump on the CA125 on a patient with already known endometriosis, which has a minimal increase in CA125, but we want to follow them up. So, if there is enhancing, so the wall can enhance, but if there is enhancing solid nodules, then definitely you are going to worry. So, endometriosis is a spectrum. It's not just the endometriomas. It affects about 10% of premenopausal women, and it's a horrible disease actually. So the hallmarks are endometriomas, that we have already looked at two cases, but also endometrial implants. And I think you'll need a specific talk on endometriosis. And my colleague, if you were to attend the webinar, the academy later in June, my colleague Sue Freeman, she's brilliant. She's going to give a whole talk on endometriosis, really going through multiple cases as well. But just to summarize here for completeness of this webinar, it's just showing you the deep bowel invasive endometriosis, and you have this implant. I mean, I've been around for 20-something years, unfortunately, and we diagnosed them with barium enemas when you had that picket fencing on barium enemas. Thank God we don't do barium enemas anymore. We have MRI, but this is a classic mushroom cup with invasive endometriosis. You can have adhesions. It doesn't have to be really invasive to the bowel. This is an endometrioma with adhesions into the sigmoid colon with obliteration of the pouch of Douglas. And this is T2 shading in this case here. Or sometimes, like in this patient here, this is recent, you just have bilateral hematosalpinges. So this could be just the presentation of endometriosis. Right. However, patients with endometriosis have an increased risk of certain malignancies. Now, fortunately, is very rare, about 1% of those patients. When they develop those malignancies, which is endometrioid and clear cell, they have a better prognosis, not because they're better tumors, but because we follow up these patients, we catch them early, and also these patients are younger. But the tumors per se are as bad as. Usually happens in endometriomas, but can happen in extraovarian disease. So, I've had a few cases, now I'm not showing one here, when you see tumor arising from that deposit, that mushroom cup in the pouch of Douglas. And as soon as you see that lesion on the follow-up, it looks like now it's invading. It looks really horrible with lots of enhancement. You have to raise that possibility. The last case we had was actually tumor arising from an abdominal wall implant, which was a clear cell carcinoma. So endometrioid, more than clear cells. The endometrioids tend to do better than clear cells. Tumors arise from endometriosis have less ascites compared to high-grade serous ovarian cancer. They also have more adenopathy. So if you see a lot of lymph nodes, you have to think about clear cell endometrioid rather than high-grade serous ovarian cancer. So just showing you a case here, T2-weighted images, 2 lesions here. They can actually coexist in the same patient. You can have endometrioid and clear cell. Large bilateral ovarian lesion may be cystic, but with solid components. T1 with fat stud. You can see the solid nodules. This is with contrast, but with subtraction, because you really want to see the enhancing tissue. If you don't subtract, you can't tell those solid nodules from the endometrioma per se. Now, it's very interesting. This patient, the lesion on the left was a clear cell, the lesion on the right was an endometrioid, both malignant. And you can't tell them apart from the clear cell tending to have more lymphadenopathy. You can also have borderline tumors arising from endometriosis or endometriomas, more rare though, rarer compared to endometrioid and clear cell. And one of the early signs of developing this is described the loss of shading. I don't think I rely on that, because I think by the time you actually see them, you've lost the shading already and there is solid nodules. So for me personally, but it's there in the literature, the loss of absence of shading is not a great indication. But enhancing neural nodules is. And again, don't forget to subtract your images or your enhanced images so you can see that pure enhancement to distinguish from the background endometriomas. Okay, so this is sort of endometrioma, endometriosis, and we're done with the T1 weighted bright lesions. Now, we're getting into the lesions which are dark on T2. And this is the range of fibromas and thicomas. It's the most common sex cord stromal tumor. Thicomas can secrete estrogen or testosterone. So then you have to have the secondary features of hirsutism, and you're going to have endometrial hyperplasia if they secrete estrogen. So this is to keep in mind when I was saying the part of the puzzle, when you have the clinical details and the clinical features. So on T1, they tend to be of low signal intensity. I showed you a classic one with that big sign. And on T2, they tend to be homogeneous, dark. However, occasionally, and I'm going to show you a sort of a lesion which is not typical fibroma, and I'll tell you why, they can be a bit of an intermediate signal intensity. However, they're still very well defined, and they're not bright or heterogeneous. So this is a patient with a chronic pelvic pain. So when fibromas can cause torsion, acute torsion, but they also can cause intermittent chronic torsion. So they do this torsion, detorsion chronically. And in that case, they get this sort of chronic edema building up, and they're not really dark, as dark as you want to be on T2 weighted images. However, they don't restrict. So you can see on diffusion, there is no restriction. And they can have this mild enhancement. So this is after contrast. There is mild, if any, enhancement of those lesions, okay? Okay, so now we're going to go to another case. This is a 23-year-old female patient. Again, pay attention to the age. This is really important. This patient presents with a large abdominal mass and a raised level of LDH. This is really important. You almost should kind of think of the diagnosis right now of what it is. It's about only one tumor which raises the LDH. Okay, so sagittal T2 weighted images, lobular sort of solid mass. After contrast, we do give contrast for this sort of young patients. And you can see there is enhancement, there is enhancement of fibrous septi more than mass per se. And you can see the ADC here on the axial plane, and there is restricted diffusion. Okay, so what do we have? We have ovarian cancer. What did I say? 18-year-old, right? Unlikely, right? Do we have a fibroma? I said fibromas are not very heterogeneous and they do not restrict that much, okay? Do we have a dermoid? Not really. This is fat with contrast, but really it doesn't fit the dermoid. Or do we have a dysgerminoma? So just, just think along those diagnoses and sort of the imaging features and also the age, right? Okay. So what we have is a dysgerminoma. Right, so they all look like this. So once you've seen a dysgerminoma, this is sort of multilobulated solid masses. Okay, they're fairly common in their group. Usually adolescents and early adulthood. So 18 is a perfect age group. They all have an increased LDH level. So again, look at your blood biomarkers. Like you wouldn't think twice on a patient with ovarian cancer looking up the CA125. Well, the clinicians, before actually, or at the same time they request an MRI, they should have requested the panel for germ cell tumors. So, and sometimes they can have increased beta HCG as well. Not always, but the LDH is your friend here. They tend to be large unilateral masses, which are solid, ISO to relatively low signal intensity on T1, on T2, lobulated ISO to slightly intermediate. They have these fibrobascular septi, which are dark on T2, but they actually have an homogeneous enhancement on T1. So you see those septi are dark. They are kind of a little imperceptible, but dark in the middle. And you see how they actually enhance compared to the rest of the tumor. The rest of the tumor enhances less, the septi enhance more. And they do restrict. Okay, right. Let's go to another diagnosis. So now we are in the young age group again, so pay attention. This patient is 17, presents with abdominal bloating and a pelvic mass, and it comes to ultrasound first, and it just looks like a horrible tumor on ultrasound. They've sent the tumor markers, and if you look them up, they have an elevated AFP, alpha-fetoprotein. And again, think about the tumors. You almost know the diagnosis now. And the patient comes from MRI. And the MRI is for confirmed diagnosis, but also to plan the treatment, surgery to start with. Right. AXA-T2 on a sort of bright but heterogeneous, signal intensity. After contrast, you can see there is enhancement with a really big necrotic areas. The other thing you see is these sort of vessels. You see really formed vessels within the mass, not just the enhancement. Okay. What do we have? Do we have a dermoid? And I haven't given you the fat sat without context, it's a little unfair. Dysgerminoma? No, because we just looked at one. So by definition, we don't have one. Although this has got necrosis, dysgerminomas don't have necrosis. Do we have a yolk sac tumor? Or do we have ovarian cancer? 18, unusual to have ovarian cancer, unusual appearance as well. Unilateral. Uterus at the back here. Okay, so we have a yolk sac tumor. Increased AFP, right? Raised AFP. Dysgerminoma, not the right appearances. MDH rather than AFP. Right, the yolk sac tumor or the endodermal sinus tumor, it's the other synonym, peak in the second decade of life. They all have an elevated AFP, alpha-fetoprotein. They're unilateral, only in 1%. I've only seen one case of bilateral yolk sac tumors. They actually coexist with teratomas in about 15%. This is the mature teratomas. Large masses. On T1, they can have high signal intensity to hemorrhage. On T2, they can have flow voids. You can see some of the flow voids. They really have formed vessels in the middle. And they have this sort of peripheral enhancement and really area of central necrosis. Sometimes when they present late, they can have ascites. Our case has ascites, as well as peritoneal disease and lymphadenopathy as well. This is our case. When I told you this formed vessel, this was a CT for further staging. This patient, you can see these large vessels within the tumor. If you see that this is almost pathognomonic for yolk sac tumor. And you see these lesions are very hemorrhagic. And this is the lesion with they've coagulated these large vessels in the tumor. Okay. Right, just to summarize the ovarian sex cord stromal tumors, majority of them are confined to the ovary diagnosis. So even if they were, they have a benign course, let's say. Excellent about 10-year, excuse me, overall survival for stage 1 and 2, which is perfect, almost 95%. Benign lesions, the fibroma, thecoma, stromal tumors, they obviously have an excellent prognosis once you take them out. Some of the potentially malignant lesions are granulosa cell tumor and sertorilating tumor. Now, this is a slide just to summarize those hormonal manifestations. They can have increased estrogen, for example, granulosa cell tumor and thecoma, already mentioned that. So if this is in girls, because they've got a bimodal distribution early, so you can have a pseudo-precocious puberty. In young women, you have irregular heavy periods, so pay attention to the sort of clinical details and symptoms. In postmenopausal women, you have uterine bleeding. Now, what goes with this is in postmenopausal women, when you have a granulosa cell tumor, look at the endometrium. Endometrium will be thick because they cause endometrial hyperplasia by this hormonal dysregulation. They can secrete androgen, and then you can see realization hirsutism, sertorilating tumor, but also some of the thecomas can do that. Right, granulosa cell tumor. It's a malignant sex cord stromal tumor. Sorry? Okay. Okay, let's carry on. 60% are in the postmenopausal women, and 80% have increased estrogen. So the lesions are very characteristic. Once you've seen one of those lesions, you basically can diagnose. It's a bit of an ant-mini. Sponge-like appearances, solid masses with internal thick septi, like a bunch of grapes. Notice here the endometrium is thick as well. Juvenile type tends to be a bit more solid than the postmenopausal one. And again, I showed you thickened endometrium. They can have areas of hemorrhage. So pay attention to T1 weighted images when you can actually see blood on those cases. This is not uncommon on granulosa cell tumors. And of course, the solid part of septi that are thick, they also enhance. Okay, case number 7. We have a 30-year-old female patient which presents with hirsutism. And we have axial T2 weighted images, a small tumor here, intermediate sickle intensity, but with some sort of cystic spaces, small cystic spaces. After contrast, there is enhancement, and the solid components restrict on diffusion weighted images. Okay, again, pay attention to clinical details. Why she got hirsutism? Because she's got increased androgen level. What is the tumor which increases androgen? Androgen, thecoma, it doesn't look like a thecoma. And the other one we said was sertoli Leydig tumor. So that's a differential. Is it a fibroma? Thecomas can, but this doesn't look like one. You know, we said there was no enhancement on fibromas or thecomas or minimal enhancement. They tend to be homogeneous. They don't restrict, so it's not this. Metastasis don't cause production, increased production of androgen, very rarely. It's good for sertoli Leydig tumors, yes. Ovarian cancer, unusual cystic solid with a lot of ascites, peritoneal disease, you know, and it doesn't actually cause virilization. Right, so our diagnosis is sertoli Leydig tumor. Okay, what are these tumors? Well, they're very rare. They happen in young women, and they all of them have virilization. They tend to be unilateral, and the imaging appearances are those. So you can see in this case on the right, the ovary is normal. This is the left one. On T2 weighted images, there are intermediate sickle intensity solid masses which have this sort of cystic or necrotic spaces dotted around. On diffusion, they have restriction, and after contrast, the solid portions enhanced. They tend to be small. Okay, the sclerosing stromal tumors now. Those are benign, peak incidence shifts second to third decade. They present with menstrual irregularity. They have this thin sickle, low sickle intensity outer rim and more of a central areas. And on T2, there are these solid masses with increased sickle intensity components. They have this spockwheel pattern. Again, this is very classic of sclerosing stromal tumor. When you have this bright mass on T2 and they have this really dark septi, one of the differential diagnoses would be a cystadenophybroma, not quite, because on cystadenophybroma, these are really, really dark and they're more abundant. And also, it doesn't enhance much on cystadenophybroma. Here you have this avid enhancements of this septi. So dark septi with avid enhancement that is progressive. It enhances even more later. Think of the sclerosing stromal tumor and menstrual irregularity. Okay, I think this is the last case, and we've got a couple more slides. This is another patient, and we're already in those the last category of the heterogeneous masses. 30-year-old immunocompromised female patient that presents with pelvic pain. You have associated ultrasound, and the ultrasound was indeterminate. Now the blood on this patient, because she was so immunosuppressed, is not helpful. So there was no raised white cell count and no raised inflammatory markers. So T2, just want to point to this fluid level, which you can usually see with certain conditions. T1 FATSA, there is no drop on sickle intensity, so it's not really a dermoid or an endometrioma. After contrast, there's a lot of enhancement, thick wall masses bilateral, and those tissue planes are quite inflamed. So what do we have? Do we have two ovarian abscesses? Do we have metastasis? Do we have bilateral endometriomas, or do we have ovarian cancer? Okay, so usually ovarian cancer doesn't present with pain, and these are really not the imaging appearances with thick enhancing walls. So that's not the case. It's no endometriomas, it doesn't fit with imaging. not really metastasis, so it just fits with the tube ovarian abscess. Right. So this is a patient. I'm just now showing the ultrasound. So you can say from the ultrasound, it's a lot of blood flow around. So this is really inflamed pelvis, but I think the MRI does help in this case. It could have gone straight to CT. Absolutely could have gone straight to CT in this case, but it did come to the MRI. So this is an immunocompromised patient. And this is classic appearances with an inflamed pelvis, really. Right, let's just review the findings. It's an ascending infection of the upper female genital tract on T1, ill-defined ISO2 low signal intensity adnexal masses. They can have variable protein and hemorrhage. So this is hemorrhage, and this is quite specific when you see this some little rim of hemorrhage on those lesions. This is due to, I mean, it's a mixture of hemorrhage, but also of granulation tissue. On T2, they're ill-defined, heterogeneous adnexal masses, but they have these thick walls, but also tissue planes are pulled and inflamed, and they have this thickened septi and edema, and it just looks like a pelvis on fire. And it gives contrast, and this is really what you see. And this, in this case, they went to surgery, and you can see pus coming out of this lesion. Okay. Right, so in summing up and leaving a good time for questions, for review, what are the take-home points? I think it's so important to be familiar with the relevant clinical history. We're all clinicians, but we love imaging as well. So I just think you can really be the clinician to the patient. Look for lesion origin, signal intensity and morphology, T1 bright masses, T2 solid, complex masses, like we went on that sort of diagrams. Contrast, solid elastic tissue is enough for me. You might want to do the curve types, absolutely fine. If you have time, no problem. It might increase your confidence as you start learning this, that's fine. It is helpful in peritoneal deposits, but what I find helpful is diffusion. If there is no restriction, it's benign. If there is restriction, you've got to really look at other characteristics. And also it's excellent, we didn't talk about ovarian cancer here as like staging, excellent on peritoneal deposits in ovarian cancer. They like shine like bright little lamps. And with that, I want to thank you for your attention. I'm going to stop sharing. And I'm going to join you.
Thank you so much, Evis, for your nice talk. We have some questions in the chat that a couple of colleagues have typed during your talk. But for the rest of attendees, please feel free to type questions because Evis will respond them. Okay, so let's start with the first question from Radu Pavel. Radu says, we tend to use 50, 400, 800, and our physicists advocate the use of 50 as a point of origin. The first question is, what do you think about using 50 instead of 0?
That's what we've started doing now. We use 50 instead of 0. Absolutely. Your ADC calculation will be more accurate. So yes.
Okay. So the second question is, can we shave some time of the investigation if we take out the 400 and leave just 2 DWI weightings, for example, 50 and 800?
Absolutely. So, and you can do that, just those 2 B values. We do that for the ovary, but we do that for which we only do in axial plane, but for the uterus, let's say for endometrial cancer, we do sagittal and axial. We do 50, 500 on the sagittal because it's lower the B value, less gas artifact from the susceptibility artifact from the sigmoid. And on the axial, we do 50 and 800. I don't go to 1,000 in the pelvis, but you can go up to 1,000. Don't go beyond that. It's not prostate, so keep it below the 1,000. Yeah. Excellent questions.
Great. Thank you. We have another question from Ruhan. How do we identify gonadal vein on pelvic MRI?
I think it's a good question because usually we're used to identify them sort of from up, sort of lower abdomen to down. To be honest, the reason I identify gonadal vein to see the ovaries, it's because it's in the literature. I mean, come on, guys, you either see the ovaries or don't. So it's a bit of an overkill, I think. So I don't use it in my practice. I literally look at the side. I identify the common iliac, the external iliac vessels, and I usually find the ovaries mated to the external iliac vessels. And this is like the normal ovaries. Obviously, when they're abnormal, you see them, easily. So maybe just ignore that comment I did. But this is the classic teaching of finding the gonadal veins, and then as you go down, you see the ovaries. Okay.
Okay, thank you. We have another question. Is a 180S contrast phase single acquisition with a very thin 0.6 millimeters BIF/Thrive an alternative to a dynamic contrast protocol? Or we must do a dynamic contrast on all contrast studies?
No, I think even if you, in the old times, we gave contrast, we imaged up to 70 seconds, like you treat like a CT, and it's good enough for Adnexal masses. So I don't think you have to overkill. Whatever you feel comfortable, you can even do one phase. Unless you're doing the curves, then you need a better temporal resolution. I would just assessing enhancement at 70 seconds, it's absolutely fine.
Okay, thank you.
But I tend to be very practical about my sort of everyday clinical routine. What is research? It's another matter, okay? So we're talking about every day, you sit in front of monitors and you just, do your work, which I enjoy very much, actually. So.
Okay, we have another question. If you find an hepatic lesion and want to characterize it, but you need a contrast also to study the pelvis, how do you protocol it?
If you find a hepatic lesion, well, if I found a hepatic lesion where, okay, let's think of the scenarios. If you find a hepatic lesion, it will be because you found an ultrasound. If you find a hepatic lesion and the ultrasound is telling me there might be malignant rather than benign, I will take this patient straight to CT, okay? However, if the question is, okay, it's a lesion, it might be actually a hemangioma, we're leaning towards that more, but also there is an Adnexal lesion, I would actually time the contrast for the liver, because I don't actually use contrast for Adnexal lesion characterization. So we use diffusion. So do the liver and then take one axial contrast enhanced image through the pelvis. So that's how I would do it if I were in that situation. I will protocol it as the liver, and then I'll do the pelvis. Does that answer the question, I hope?
Thank you, Evis. Next question. Do you have any scanning protocol recommendations for examinations in pregnant women with suspect ovarian cystic mass?
So in pregnant women, we tend to use faster sequences. So we do, rather than using the high resolution FRFSC on the G scanners, we use SSFSC. So you want to do faster imaging to also minimize the artifacts. Again, most of the lesions will be, think about, during, when we do the academy, I'm going to do a bit of a, what do we do in pregnancy? I think you've got to be very practical. So in pregnant women, most of the lesions are going to be benign. Very, very rarely you're going to find a malignant lesion, ovarian cancer. It does happen, but usually you'll find a borderline at most. So you have a window to actually to image in order to do surgery. If let's say it's a borderline or a malignant tumor. After that, you really are going to wait until the end for the surgery. So the protocol pretty much remains the same. We don't give contrast unless we absolutely need it. I don't think I've ever given contrast for a pregnant patient, definitely not in the first 3 months of pregnancy. So I will do the same protocol, and that's why without giving contrast becomes short, and I'll try to shorten the T2 weighted images. So just acquire an SSFSC rather than the FRFSC. I'm talking G terms.
Okay, great. Next question. Should ovarian abscess be always associated with tubal pathology like hydrosalpinx or pisoalpinx?
Not necessary, but usually it is. Even if you don't see it, like in the case that I showed you, you'd almost see it like two cystic, ovarian masses. Almost invariably, you'll find an element of a pilosalpinx. Unless sometimes you have tubal ovarian abscess, like endometriomas can get infected. And I've got a very nice case of that, which I didn't show here, when an endometrioma, it's almost, you have to be careful when you read, we read the case as a follow-up. And then actually very helpful in clinical detail, he said, but the patient now has quite a lot of pain. And then we looked up the blood, and then the white cell count was up. And what you do, you lose the shading when you feel an abscess there, and then you don't have loss of T1 signal intensity. I mean, it becomes an abscess basically, and you've got the trim enhancement. So you don't have to have, but most of them, it's a complex. The tubes are involved.
Okay, thank you, Evis. We have another question. What sequence do you think works best for a small endometrial implant? T1GRE-IFS, T1FS Dixon, or Vive/Thrive?
I mean, whatever you want to do. We use a standard, FATSAT on a Dixon. It depends. Your protocol is something that you want just to be familiar and comfortable with, and depends on the scanner you use. All my life I've been a G user, not necessarily by choice, but I got used to, and I get great images with the scanner. So I think the piece of advice is work with your physicist and application specialist, whatever you're using, whatever sequence you're using, so that you're happy with your images. So there is no recipe to what sequence you use.
Okay, great. There are no more questions at the moment, but if someone has a question, please type it in the chat. Meanwhile, we wait for questions. Please let me remind you that we will send an email to all the attendees granting access to the webinar. This webinar, it's going to be accredited, and you will need to respond 3 questions, okay? And we will send you a detailed email with all the information. And also, please remember that in case that you would like to have a close look at this topic, Evis, along with her colleague Susan Freeman, they are organizing 2 online fellowships about pelvic female imaging, where the first ones of June are almost fully booked, a few seats left, and we have another edition in October. Really popular topic that we launched recently, and the radiology community is accepting very well this topic. So thank you so much. I cannot see any more questions, so I think that's all on our side. Thank you so much for all the attendees. I hope that you had fun during the session and learned a lot. And thank you, Evis, as well, for your effort preparing this amazing webinar. We are really happy with the result.
Oh, thank you for attending. It's been a privilege. Thank you.
Goodbye, everyone.
Bye-bye.